This is a well-defined lesion that's located in the subcutaneous tissue superior medial to the left orbit. The lesion is well-defined on all acquisitions and shows no invasive features into the underlying frontal sinus or into the left orbit. Importantly, the lesion shows no soft tissue components or enhancement after giving contrast and has a very homogeneous internal appearance. In general, the lesion does not show any aggressive features. However, the hint to this lesion is seen on the acquisition that you see in front of you. You have noticed that the abnormality is bright on the T2 weighted sequence. However, it's also very bright on the T1 acquisition. Since most lesions are hypo-intense on T1, hyperintensity on T1 is a very important hint. Several things could give you hyperintensity on T1. The most famous would be contrast administration. But remember that subacute hemorrhage and fat are also hyperintense on T1. Other substances that could be bright on T1 would include melanin, protein, manganese, and some calcium. An easy way to know if the composition is that of fat is to look at the fat-suppressed sequences, such as this fat-suppressed T2. So the abnormality that was bright on both T2 and T1 sequences shows loss of signal on this fat-suppressed T2 acquisition. This is consistent with a benign lipoma. The teaching point from this case is to remember that some material could be bright on T1, a piece of information that would make your differential diagnosis a bit easier. Things that are bright on T1 would include contrast, subacute hemorrhage, fat, melanin, protein, some calcium, and manganese. Thank you for watching. More cases later this week. Although this chest radiograph may appear normal on a first glance, it has a very important finding that you have to keep in mind all the time. A golden rule in assessing chest radiographs is that the lung markings should reach all the way to the periphery. Let's look at the magnified image of this normal right lung. Notice how the lung markings reach all the way to the periphery. Now look at the abnormal left lung. You'll see two things. One, there's a thin line that parallels the chest wall. Two, there is absence of lung markings beyond that line. Notice how you have a completely lucent hemithorax in this area. The findings are consistent with a left pneumothorax, air within the pleural space. So the two signs of pneumothorax on a standing chest radiograph includes a visceral pleural line and lack of lung markings beyond that line. Although this is a short case, it contains two very important teaching points. The first teaching point is to remember that a normal lung should show lung markings reaching all the way to the periphery. Teaching point number two is about the signs of pneumothorax on a standing chest radiograph, including the visceral pleural line and absence of lung markings beyond that. That concludes today's case. Thanks for watching. We would really appreciate your feedback and comments as usual, and see you later. On evaluation of abdominal chest radiographs, evaluate the bowel gas distribution and the soft tissues, but don't forget evaluating the bones. This patient has diffuse, heterogeneous, increased bone density, something we call osteosclerosis. The same appearance is seen on the patient's chest radiograph. Notice how the spine density is generally increased. Causes for increased bone density include a relatively long list that could be remembered by the following mnemonic: Prof 5Ms. I'm going to go quickly over the list of differential diagnoses according to this mnemonic. However, not all of these diseases are common or important. So the P stands for Paget's disease and pycnodysostiosis. The R stands for renal osteodystrophy. The O stands for osteopetrosis and osteopoikilosis. The F stands for fluorosis. The M stands for metastases, a subset of myeloma, mastocytosis, myelofibrosis, and metabolic causes. The S stands for sickle cell disease. Now, as we mentioned, some of these entities may be very rare, not that important, and some of them might not exactly look like diffuse osteosclerosis. Although Paget's disease, for example, could give you increased density, it's characterized by cortical thickening bone expansion and coarse trabeculations, which we don't see here. Pycnodysostiosis is a very rare entity that could be seen in a pediatric population or adolescent population. Osteopetrosis is another pediatric entity that is not seen in adults. Tuberculosis is a rare entity characterized by multiple tiny spots of increased density known as multiple bone islands. So we're left with common entities that could be characterized under either neoplastic, metabolic, or sickle cell disease changes. Although myeloma is a neoplastic entity that is common, it's usually associated with decreased rather than increased bone density. A very rare subset of myeloma may be associated with increased bone density. Metastatic disease to bone is very common and could be lytic, sclerotic, or mixed. The classic metastatic disease that could give you sclerotic bone changes is that of prostate cancer. Myeloproliferative disorders such as mastocytosis and myelofibrosis are relatively commoner than the other entities and may be seen in adults. Metabolic entities such as increased fluoride intake leading to fluorosis or increased vitamin intake such as hypervitaminosis A or D can give you the same thing. And in regions where hemolytic anemias are common, this could be a very common presentation of sickle cell disease. This patient was known to have chronic renal failure, and all the changes that you see within the bones are related to renal osteodystrophy. The first teaching point is never to forget looking at the bones, whether you're looking at an abdominal or chest radiograph. Second teaching point is to remember the long differential diagnostic list for osteosclerosis. Although you could remember this by the mnemonic Prof. 5Ms, the common causes would be metabolic, neoplastic, or sickle cell disease. Thanks for watching. Hope this was useful. More cases later this week. This is a very basic case. The most important thing that you should notice on this chest radiograph is the presence of subcutaneous air. Air in the subcutaneous tissue is known as subcutaneous emphysema or surgical emphysema. The presence of air in a subcutaneous compartment should make you look for air in other compartments, such as air in the pleura, the pericardium, or mediastinum. In this case, there is no pneumothorax, there is no pneumopericardium, but there is pneumomediastinum. Notice the linear strands of lucency representing air within the mediastinum here and along the left mediastinal border. This is a case to remind us to always look at the periphery of the film, and one of the things they could look for in the subcutaneous tissue would be subcutaneous emphysema. The second thing to learn here is that once you see subcutaneous emphysema, make sure to exclude pneumothorax, pneumomediastinum, or pneumopericardium. Thanks for watching. More cases later this week. With the provided history, you would like to look for a pituitary adenoma. This is a coronal T1 acquisition from a pituitary gland MRI. Before we continue, pituitary adenomas are classified into microadenomas if they are 1 centimeter in size or smaller, or macroadenomas if they're larger. I will go over a few landmarks to be more familiar with the anatomy on this coronal image. This here is the pituitary gland living within the sella turcica, just above the black area representing the sphenoid sinus. The CSF containing space above the pituitary gland is called the suprasellar cistern, and it contains the pituitary stalk, the linear thing here. There is a cavernous sinus on each side of the pituitary gland. Within this sinus, there is the internal carotid artery, the dark circles. Another important structure is this here, which is called the optic chiasm. If we go posteriorly, this is the optic tract joining at the chiasm to form the anterior directed optic nerves. Apart from a few exceptions, the superior border of the pituitary gland should show no bulges. You see a relatively flat surface here compared to this side. Just by looking at this image, you're sure that you don't have a pituitary macroadenoma that exceeds a centimeter. But do you have a microadenoma? Without administration of intravenous contrast, microadenomas may be missed, since most of the microadenomas are iso-intense on T1 and T2. The way to look for microadenomas after giving contrast is to do what we call a dynamic post-intravenous contrast acquisition. By dynamic, we mean giving the contrast and following the enhancement of the pituitary gland by performing several images over time. Notice how the pituitary gland enhances intensely and how the pituitary stalk enhances as well. However, there is this area where there is no enhancement early on the dynamic post-intravenous contrast acquisition. This is easy to appreciate on the early acquisition. However, look what happens to the microadenoma as we proceed. So we're going to the next enhancement slide, the one after, and the one after. Even microadenoma would enhance if you give it some time. So if you only acquire a late image, it might be difficult to see such an abnormality. From the provided clinical information, the clinician already knows that the patient would likely have a functioning pituitary adenoma. What the clinician really wants from the radiologist is to assess the relationship of this abnormality to the important surrounding structures. I'd like to know from you if there is extension into the supracella cistern and compression of the optic pathway. He would also require information about the status of the adjacent cavernous sinus and the internal carotid. Additionally, he would like to know as well the status of the sella turcica, if it's expanded or remodeled, as well as invasion into the paranasal sinus. We learned a few things from this case. The first is the normal anatomy of the pituitary gland and what surrounds it on a coronal T1 acquisition. The second thing we learned is that pituitary adenomas could be classified according to a 1 centimeter cutoff into micro versus macro adenomas. The third thing we learned is that microadenomas do enhance if you give them time, so if you do not perform a dynamic acquisition, you might miss them. Finally, whenever a pituitary lesion is seen, the relationship of this abnormality to the important surrounding structures should be addressed. Thanks for watching. Please continue sending us your feedback and comments, which are very useful to us. See you later.